All right, so welcome to our Wednesday coding practice, folks. We are going to continue on with CPT coding practice. This is going to help everybody. Those of you that are older who can use a refresher, y'all that are about to graduate and get out of the program, getting ready for that exam, and my new students who are just getting introduced to CPT. Today's going to help out a lot to clarify some things for you guys. So we are going to jump right in. Those of y'all that can turn on your cameras, please do. If you can't, that's fine as well. I would love for y'all to follow along and chime in. Feel free to take yourselves off of mute and answer any questions if you're able to follow along. Shout out page numbers when you get them, all that fun stuff. But we're going to go ahead and jump right in. All right, so, and I'll be following along with y'all. I've got my manual here too. So, a new patient home visit. And this says E&M, which means evaluation and management. This is problem-focused history and exam, and straightforward MDM. And for my new students, MDM is medical decision making. Whenever you have an office visit or a home visit, or the physician sees the patient in the hospital, whenever the physician sees the patient, they're looking for three things to determine what level E&M code they're going to use. An E&M code, evaluation and management, are your codes that cover new and established office visits, counseling services, just all kinds of different physician services. When they go to see somebody in the nursing home or the hospital, or they go to see them at their house. And I know it's not commonplace for doctors to make house calls anymore, but it does still happen. I used to be the billing manager for an urgent care clinic in Shreveport that did house calls. On urgent care basis, they would jump in their little car and go on out there. So it is still out there. It's just pretty rare to see it. But so this would be, say that urgent care went to see a new patient that they had never seen before at their home. And this was, they looked for, there's different levels of evaluation and management. The more history you have to take, the longer exam time, and what they call medical decision making, the more involved it is, the higher level in E&M code you're going to have. Okay. And they start at like, I think 92011, and that code's not even used anymore. But that's, I think, a new patient office visit, 92011, if I remember correctly, right off the top of my head. And they go 92011, 92012, 92013, and 14, and I think all the way to 15. And the more complex, the more that's wrong with that patient, the longer they have to spend with that patient, the higher level code you're going to use. Okay. The more complex the problem, the higher level code. The more history or records you have to look over for that patient, you're going to have a higher level code. Okay. And the reason for that is we want that doctor to be able to get compensated for all of the time that they spend with that patient. So it's not, because it's not fair for them to spend 30 minutes with one patient and get compensated, X amount of dollars, and spend an hour and a half with another patient and get paid that same amount, right? They should be paid more if they're doing more work, if they're spending more time. So the higher level of code, the higher level of compensation for your provider. So you want to make sure that you're getting the right E&M code. And there's two ways to go about finding this in the CPT manual. Okay. The E&M codes have their very own chapter in the beginning of the book. If you have tabbed your manuals, you may have found this at the beginning of the book. Let me see what page it starts on. Page 5. So that tells you how early on in the book it is. E&M codes start on page 5, all right? And you go through a lot, there's a lot of guidelines that go along with E&M codes and different, like counseling services and stuff like that. It has to meet certain criteria for you to be able to use certain codes, right? So that's the first way to look for them, to go to the E&M chapter, just like you go to any other body system in there, okay? And then the other way to do it is right before that E&M chapter, there's like a few pages that have kind of like some shortcut tables that have all the E&M codes, and they have problems. They have history, exam, and MDM, medical decision making. And you just pick what level it is, and it shows you which CPT code you need to use for that E&M. Okay. And that's actually where I generally start to tab my manual, is at that those tables, because they're so handy, right? So you can go either which way. Which way do y'all want to go? Anybody have a preference?
No, what's the best way to go?
Um, for me personally, I like using little tables because you don't have as much reading to go through, not as many pages to look through. I find it a little bit faster and it's a little bit more to the point, right? Like if you go to the definitions in the chapter, it's going to say must contain this, must contain this, and must contain this. And then it's going to give you the next code. And in that definition, it's going to say must contain this, and this. And so either you got to sit there and go through all those to determine which one it is, or you can look at this handy dandy little table that they put together for you and just knock it out real quick. So that's the way I prefer to go. All right, so let's do that. Let's go by the little tables. So they start before the page numbers even start. Page XXV, which I don't know what that is in Roman numerals, but XXV is the page. And when y'all turn to that page, you'll see it says evaluation and management tables. Okay. And it
Okay.
says the first thing you see is office or other outpatient service. And the reason they have that first is because that's the most commonly used. Anytime your patient comes to a doctor's office, they're going to have a code off of this little table right here. Anytime. So now for ours, this is a home visit. So that's what's considered a house call. So you can do one of two things. We know that it's going to be an E&M, so we can go straight to these tables, or you can look up house call in the alphabetic index and it'll lead you to the E&M chapter. So like I say, multiple ways to skin a cat. I'm going to skip straight to the tables because I'd like to show y'all how they work. So I'm going to flip through these tables until I find house calls, home visit, something to that effect. All right. And it's only 3 pages of little tables, y'all. That's it. 3 pages. And this one happens to be on the 3rd page, page XXVII. And if you look, the middle column, bottom half of the page, it says home services. And if you look next to it, it also says home services. And sorry about that. The first thing is it describes your patient. Is it new or established? Well, we know from our scenario, this is a new patient. So we're going to be using this first table, right? All right, and it says problem focused history and exam. All right, so you see that first little section in the table is history and examination. And then it lists underneath the different kinds, different levels that you can have. Problem focused, expanded problem focused, detailed, or comprehensive. And like I said, the more that's wrong with the patient, the higher level it's going to be. So problem focused is we're focusing on this one thing that this patient has come in to see us about, right? Expanded problem focused is okay, they've got this one problem, but they've got other stuff going along with it. Detailed, we're getting into some heavier stuff with detailed. We've got more history or more of an exam that's needed. We're getting serious about stuff there. And comprehensive is when you have a really sick patient. They're terminally ill, they may be dying, maybe somebody on hospice, something to that effect. Okay. And that's the highest level that you can get to, is that there's like a, a threat of death, a threat of death going along with that. Okay. So ours, problem focused history and exam. So that's going to be that top row, right? Problem focused. And you'll see how they have the CPT codes listed across the top, 99341 through 99345. All right. And each of those is a higher level. You see how the X's kind of, as the levels get higher, they move along to those different codes, right? So we're looking at problem focused history and exam. So that's that first column. All right. And then medical decision making, they're saying is straightforward. And that's just the next little section in the table. Medical decision making and straightforward is also in that first column. Okay. And there's also sometimes there's other, if that's not straightforward enough for you, or if you get different columns, there's more details that you can add in there if you keep going down in the table that can help you decide which one to use. Contributory factors, extra things, right? Presenting problem severity, low, moderate, moderate to high, high, unstable, or significant new problem. Okay, so again, those are by level. The more serious the complications, the higher the level. All right, but so for ours, it's a new patient, it's straightforward, it's problem focused. Everything's lining up for us in that first column, right? So our code, our E&M code, the answer to this one is going to be 99341. You just follow the table. That's all you do. You look at what kind of history and exam you have, you look at your level of medical decision making, and you line it all up. It's not that easy peasy. I like to think easy peasy. For me, a lot easier than going in the chapter and reading each one, each definition for each CPT code and seeing what each one has involved and all that. Does that make sense to everybody?
Yes.
Awesome sauce. Good deal. Good deal. All right, so that's a short little explanation on E&M codes. So anytime you see office visit, any kind of visit, visit is a keyword. Anytime you see visit, you're gonna be looking for an E&M code, and they're not always gonna tell you like I have it here, E&M. Sometimes they're gonna make you guess at it. So, but anytime you see office visit, home visit, nursing facility, anything like that, you're gonna be looking, or counseling services, you're gonna be looking for an E&M code. Okay. All right, so let's move. If that one made sense to everybody and y'all don't have any questions on that one, we'll move into the next one. All right, so closed treatment of an ankle fracture, medial malleolus. That's what I'm going to guess, malleolus, with manipulation without fixation. Okay, so we have the closed treatment of an ankle fracture. All right, so we're looking for our procedure, our keywords for our procedures, right? So procedures, what's done to the patient. So for this one, what's our procedure? What are we doing for this patient?
Treating ankle fracture.
Exactly. We're going to treat this ankle fracture. So in the alphabetic index, like I say, there's more than one way to skin a cat. You can start several different ways with this, okay? You can start by looking up fracture and then finding ankle indented down and go from there. You could also probably go medium malleolus, I would bet. but I would go ankle fracture. That's kind of, you know, straightforward. And we should get some options under that, maybe with manipulation, without manipulation, and things like that. So that's where I would go. I'd go to fracture in your alphabetic index and then find ankle and see where that leads us. And I'm going to do the same on my end. Do, 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 do. All right. Anybody found it in the alphabetic index? I'd give y'all a page number, but it's probably going to be wrong because I'm in the 2022 manual.
It's 1127.
1127. Thank you. All right. So you see where it has fracture, and then it indents down and it starts listing all your different places in the body you can have a fracture, right? So ankle is going to be not far down. We have ankle, and then it indents down and gives us 5 different options for ankle fractures. Okay? Bimalleolar, lateral, medial, posterior, trimalleolar. So we're looking for medial, right? Right. All right. So medial is it's given us a range of codes 22760 through 27814, which is a big range. Big range. So we're going to go to the very beginning of that range, and that's where we'll start in our chapter, right? So 27760. Let's find that in our chapter. And y'all just spit out a page number when you have it. And y'all, I'm gonna pause it and jump up.
187.
Thank you. I'm gonna pause it and jump up for just a second, guys. My husband just got home early from work and is about to walk in the door. So I'm gonna just tell him to be quiet, that I'm in a meeting. He doesn't know. So just give.
I'm sorry, that's 186.
All right. Sorry about that, y'all. Okay, so what page did y'all come up with?
It's 186.
Perfect, perfect. Thank you so much.
Mm-hmm.
All right, so once y'all get there, you're gonna see that you have the section starts with fracture and or dislocation, and then it starts listing the codes. So 27760 is where ours starts. So let's see. Closed treatment of medial malleolus fracture without manipulation. All right, well, that doesn't fit us, right? We need with manipulation and without fixation. So I'm going to go on to the next one and see what it says. 27762. With manipulation, with or without skin or skeletal traction. Okay. Okay. So it gave us, I'm going to keep going because that seems like it fits, but not exactly. So we're just going to keep going a few more just to make sure that that's the closest thing. All right, so 27766 is open treatment. That's a no-go. 27767, closed treatment of posterior malleus fracture. That's not us.
Nope.
And the rest of them, it's all different stuff. So, do you believe that 27762, the with manipulation, with or without skin or skeletal traction, is going to be our code? That's the closest matching one that we have. 27762.
Right.
Does everybody see how I got there? My reason.
Yeah.
Oh, look, we have a pudding.
I gotta stop. I have to stop choosing the right one and then thinking hard more about it, scratching it out, and then putting the wrong one.
You're probably overthinking it, which is common.
I'm overthinking it.
You're overthinking it. Yeah. Look, y'all, we have a pudding with us today. DeAndrea has got a pudding. We love the babies.
Why I can't see everybody else?
We love the babies. Oh, and I love it when y'all bring them to class too. And I'm not being facetious. I really do love it because I like seeing everybody's kids. All right, so very good. Any questions on how I got there or how we got to that one? Nope. Awesome. All right, we got one more page, couple of more to go through. And this one kind of sounds scary. It's not nearly as crazy. Bilateral burr holes for drainage of a subdural hematoma. All right, so the first thing that pops out at me, keyword wise, when I read this is bilateral. Can anybody tell me why? Why I'm keying in
It
on
tells
that?
you. It tells you where.
Right.
How, well, yeah, where?
It does. It tells us that this was on both sides of the brain, right? For y'all that don't know, burr holes are holes that they drill in the skull for different reasons. Sometimes it's for drainage, sometimes it's for biopsy. It can be for a whole lot of different things. But anytime they need to drill a hole, sometimes they're called burr holes. And this means that they did it on both sides. And there's a reason why that's important. Anytime you have a procedure that's done on both sides of the body at one time, you have to use a modifier indicating that it was bilateral, right? So I'll get into what modifier we use for that in just a minute. But so bilateral burr holes, okay, for drainage of a subdural hematoma. I would start at burr holes. Just go straight for it. Start at burr holes in the alphabetic index, and let's see where that gets us. Drainage. Okay. Spit out the page number whenever y'all find it, guys.
It's 1072.
Page. It should be like 1,000, maybe 60 something.
Yeah, 1072. You said burr. We're going to burr holes first,
Burr
right?
holes. Yeah. Burr
Yeah,
holes.
1072.
Perfect. Thank you.
Mhm.
All right. So when y'all get there, you'll see in big bold letters burr hole, and then it goes by reason for burr hole: aspiration, biopsy, catheterization, drainage, exploration, implantation. Like I said, there's a lot of reasons why they'll drill a hole in somebody's head. But ours, we need drainage, right, of a hematoma.
Mhm.
So It says for drainage, and then it indents down and it says abscess, cyst, or hematoma. So that's easy. We go straight to the range it gives us for hematoma.
Mhm.
61154 through 61156. So let's go find that in our tabular index. Should have that. Apparently I don't.
Let's see, we're 452.
What did I say? 6. I usually earmark them, y'all.
452.
Yep. All right. It's not the same page for me.
Oh, it's not.
No, because I'm in an older I'm in
Oh.
an older book. My book's outdated. Y'all's is pretty fresh. Let's see, 61154. Well, why am I not seeing it? There we go. Okay, I was just overlooking it. All right. So we see twist drill, burr holes, or treppin? I'm not sure what that is. I've actually never heard of that before. But so it's given us a little range there. So we'll start at the beginning of the range. Burr holes with evacuation and or drainage of hematoma, extradural or subdural. That sounds about dead on, doesn't it?
It
61154.
does, but
Burr
there's
holes.
more.
There are, but if you look, evacuation or drainage of hematoma, if you look at 61156, burr holes with aspiration of or hematoma or cyst intracerebral. So that's not going to match.
But
Insertion,
underneath, we have to use a modifier with 61154, right?
correct.
Okay.
If it's bilateral procedure.
Yeah. Isn't that, yeah, bilateral?
Uh-huh. Uh-huh.
That's us, right?
Good catch. Good catch. That was the next thing I was going to point out. All right, so 61154 is going to be our code. And then you'll see it says it right there. For bilateral procedure, report 61154 with modifier 50. So it even gives you what modifier you need to use right there underneath the definition. You don't even have to go to the modifier section and try to point that out. Or try to figure that out. Like I said, y'all, the books really give you all the information you need to do it correctly. And what's great about this, like let's say that you're working in an office and you have this come up and you don't catch off the top of your head when you get the super bill that it's a bilateral procedure that needs a modifier, and you just code it 61154 and send it on to the insurance company. So what's going to happen then is the insurance company, once they see in the records that it was bilateral, they're going to say, no, we can't pay this claim because it's not coded correctly. So they're going to send it back to you. And at that point, all you have to do is correct it and resubmit it. You correct it, add the modifier on it, and you send it back to the insurance, and they should pay it. Okay. Now, if they should reject it again, that is when you will make a phone call to that insurance company and say, hey, you rejected it for no modifier. I added the modifier and you rejected me again. What's the deal? And at that point, they're going to tell you whatever they're going to tell you. And you can tell them, if you looked it up beforehand and made sure that you use the correct modifier and all that, you can tell them, no, I looked it up. I checked all the, this resource and this resource, and it said modifier 50 for a bilateral procedure. That's what I put, pay my claim, right? Sometimes you'll have to argue with them, and that's okay. That's part of the job sometimes. But you got to know what you're talking about. You got to have data to back yourself up. You need it in black and white somewhere to back up what you're saying, okay? And a lot of time you may get somebody new and they're going to be reading off of a script. And you may have to ask them, hey, if you can't talk to me off of the script about this, put somebody else on the phone. Okay? Don't be afraid to do that. Nothing wrong with that. It's perfectly acceptable, perfectly normal in the insurance and billing world to ask to speak to somebody else, because you can't have a conversation with the person you're on the phone with. So it happens, and that's okay. Okay. But so does everybody see how we got there? Yeah.
Yes, I
Awesome.
do.
Awesome. All right. So this last one of the things I tell y'all, or advise y'all to do, just to get used to your manuals and things like that, is like, hopefully y'all are all very healthy and y'all don't have any chronic illnesses and things like that going on. But if you do, or you can recall some injury that you had, some procedure you had done, look that up in the CPT manual and just figure out what the code for it. Nobody knows what your procedure was like you. So you should be able to go in your book and find this. And this last one is actually, I was having trouble coming up with ideas for today's class. So I went ahead and used one of my own procedures that I've had done. Unfortunately, I've had this done twice, or attempted once and successfully done the second time. But so this is, y'all are coding me today a little bit. All right, so this one is a cervical cerclage, vaginal approach, 15 weeks gestation. So when we're picking out CPT codes, um, sometimes how far along a patient is in pregnancy will matter, and sometimes it doesn't. Okay. When it comes to the ICD-10 codes, your diagnosis codes, it matters almost every single time. What trimester, how far along in the pregnancy the patient is. Okay. Um, but for CPT, it's sometimes it matters and sometimes it doesn't. Okay. But what does matter is whether or not this took place during a pregnancy, or if the patient was not pregnant at the time. That does make a difference in the coding. Okay. When it comes to these gynecological procedures and stuff like that, whether the patient is pregnant or not at the time of procedure does come into consideration for a lot of the procedure codes. Okay, so a cervical cerclage. Does anybody know what that is? That's where they go in and, like, your cervix is supposed to be closed during pregnancy, and then when you go to have the
They sew
baby,
it up.
it opens up, right? Well, sometimes during pregnancy, it'll open prematurely, and in order to keep baby in place, they sew it. They sew it closed, so baby can't go anywhere. So we're gonna look up cerclage, because there's actually different places in the body that you can have a cerclage done for different reasons. So we're going to look up cerclage in the alphabetic index, and then we're going to read down our indentions and find cervix or cervical. Okay, so let's do that and we'll see where it takes us. All right. So for me, it's like page 1063. It's probably 1070 something for y'all. Excuse me.
No, for us it's 444.
In the alphabetic index?
The alphabetic index.
In the back of the book?
Oh. Here we go. Yes, 1079.
1071?
79.
79? Perfect. That's about right. All right. So you'll see where it says cerclage in the bold blue letters, and then it starts listing the different body parts, right? Cervix, femoral fracture, humeral shaft fracture, tibial shaft fracture. All right, so of course we want cervix, so that's our top option. And then it indents down to abdominal, removal under anesthesia, and vaginal. So I am going to guess that that is the approach, the different approaches that you can have it done by in the cervix, and ours is vaginal. So that gives us code 59320 is where that takes us. And it doesn't give us a range, so it should be straightforward, but we still have to check it out, right? We always verify, right? So 59320. All right. So what page was that y'all found it on?
444.
444. Perfect. All right. So you will go to code 59320. Cerclage of cervix during pregnancy, vaginal. That's pretty much it. She's 15 weeks gestation, so it is during pregnancy. It was a vaginal approach and cerclage of the cervix. All right. And if you want to read the codes around it just to make sure, there's nothing wrong with that. But this is pretty straightforward. It's going to be 59320. Any questions on how we got there? That one was pretty straightforward. That was a good one. All right, so that's it for today's coding practice. I hope this helped clarify. I know there was a lot of information in today's for you new folks, especially with the E&M codes and stuff like that. So if y'all are working on stuff later and have questions, as always, please reach out to me. In fact, I had one of y'all reach out about a question on the exam and clued me into the fact that the exam answer was wrong. So I had to go in and correct the exam answer. because the codes have changed and the code that they had as the answer is no longer the answer. Um, it's been updated over the past couple of years. So my answer was incorrect in my grading thing, and I had to go correct that. So good catch to Miss Caitlin. And she reached out. She was like, "Look, it said the answer was this. I came up with this. I don't understand why." And I was like, "Let me grade your exam. I'll look at that question and we'll figure it out, and I'll explain it to you." And when I went in, I figured out that her answer was correct and the test was wrong. So y'all, don't ever be afraid to reach out with a question if you're thrown off by something. Okay. Um, we will get to the bottom of it. I will help clarify whatever I need to for y'all. So just please don't ever be afraid to reach out, and please don't think that you're bothering me or your question's silly or anything like that. Okay. Don't think any of that. We're gonna have our 4 o'clock weekly class meeting tomorrow as per the usual. I think that's about it. We're already almost halfway through this module. So I've actually got like one or two of y'all that have done almost nothing so far in this module. Don't do this to yourselves, guys. Don't let yourself fall behind like this. You're gonna get when in next week when I say, okay, the module's about to close, you have 3 days to catch everything up. Don't do that to yourselves. Don't put yourselves under that kind of pressure. All right. Daily is the way to go for this, guys. It is really, this program is not hard if you work on it daily, because if it's daily, it just is a little bit of time every single day. But if you wait till those last few days and try to cram it all in there, you're going to end up with a not great grade. And if that GPA falls below 2.0, you end up on academic probation. And if in those next couple of modules you can't get that GPA back up, you end up getting dropped from the program. So you got to keep up the grades, guys. That GPA has got to stay above 2.0, okay, to complete the program. It's a requirement by the State Board of Education. So very important. It's a rule that we have to operate by. So and that's the way it is. That's what it's got to be. So if y'all need me to reopen anything, those of y'all that are behind, I'm more than happy to do that. Y'all know that. Just reach out to me, please, and we can do that. And there are so many of y'all that are kicking butt and taking names in this program right now. I'm just super proud of y'all. So just keep up the hard work and just keep on rocking and rolling.
I have a question.
What you
When I
got?
came in, I was late getting something, so I could never catch up with um everything that we had first started on. So I didn't
Uh-huh.
get to put everything in.
That's
Is,
okay.
is that okay or
Yeah, you had extenuating circumstances. So the stuff that you did not get to complete, I actually dropped those grades for you. So
okay,
that
okay.
was not your fault. So you're not going to be counted against for that. Yeah. So
I'm
those
like,
those
why did
grades,
you do that?
yeah, those grades that you didn't get to complete, I dropped those assignments for you. You don't have to worry about those. You'll
Okay.
and that's why I'm so glad that you're coming to the coding practice classes, because that's what that work that I set y'all was. Chapter 8's an introduction to what we're working on here. So you're fine.
Okay.
You're doing
Okay.
fine. You haven't missed
Okay.
out on anything. You're not behind as knowledge wise. You're doing great, Miss Theatre.
Okay.
The
Thank
rocky
you.
start that you got,
I'm trying.
you're doing great.
Thank you.
Right, folks. Well, do y'all have any questions, concerns, anything else for me today while we're here? No?
That was it. Yeah, I'm good.
Awesome. Well,
I
just
think
reach
that,
out
yeah, I
if you
got
come
it.
across anything later. Okay.
Okay.
Otherwise,
Okay.
you guys have a blessed evening, and I will hopefully see y'all tomorrow.
Okay, thank you.
Bye, guys.
Bye bye.